and I thank TCT Plus as well as STEMI India for calling us here. And today my topic is basically in STEMI role of imaging as well as physiology, especially multivessel presence in a case of STEMI. So you can just divide this into two things. So when you just treat a multivessel disease with a STEMI, you have both culprit and non-culprit. So what can we do with this? So we'll just concentrate on imaging, how it helps, especially in culprit vessel. I have been asked so many times, including Dr. Srinivas Kumar and my friends, how often do you do imaging in STEMI, especially for the culprit vessel? So it's a very important thing that basically we all know that the pathology or the etiology for ACS is basically all these things: plaque rupture, erosion, as well as nodules. And treatment for each of these things is different. So to know that what type of treatment we are going to give this patient, definitely imaging has a great role there. So I'll just show you some of our cases as well as the guidelines and some few evidences what we have for this today. So whenever you do an angiogram in a patient with STEMI, if it is a very clear-cut culprit, there is no doubt you can go ahead and do the PCI there. There are so many times that there is an ambiguous anatomy, you're unable to make out what is the real etiology, and really you need to think about the treatment. Probably intravascular imaging gives you an excellent idea. So this is a clear classical example of a ruptured plaque in an MI, where you know that the plaque lumen area is also reduced and it is a plaque there. You know the characteristics of the lesion. It's a straightforward lesion. You can just go ahead and stent there. Many times what you do is, what we get is, look at this case here, and again a total LAD. And then most of the time when there is a thrombotic occlusion, today we have few options, many options, which apart from thrombectomy, we have laser or something, whatever thing you can do, you can reduce the thrombus burden there. And once this thrombectomy was done, this is the angiogram here. So generally in a patient, like in our routine practice in PAMI, you generally tend to put a stent there directly when you have an angiogram like this of the thrombectomy. So is it definitely needed or what? So you do an imaging there, do a OCT there. Look at this OCT, what it is showing is, it's clearly, it is a full of thrombus there. And behind the thrombus, you really don't know what it is. But many times, my colleagues say that, or probably my friends ask, there is a lot of thrombus, how do you make out the pathology? There are certain techniques. So you look at the longitudinal view in this OCT, you just concentrate behind the thrombus there. You see that if there is any plaque rupture, at the same time, you get to know what is the lumen of this vessel. And this patient, we did not do anything since it was fully thrombus. And 2 weeks later, you do a check angiogram, it is like this. You do an OCT if you want. This is an example there where the entire lumen is very clear. So this patients, you need not put a stent unnecessarily, especially in a younger patient. You can just manage them with medication. Probably this is an erotic plaque with an adequate lumen there, nothing much below, can be treated medically, which you cannot decide on an angiogram. You cannot leave it like that based on an angiogram finding. And coming to this typical MI, I think most of you come across with such type of STEMIs everywhere. So this is a very important point that we should see how to treat this type of patients. So the main aim is to avoid slow flow, have an adequate expansion, and to do that, there are certain things that we all know that not only thrombus, it is a lipid-rich plaque. When you dilate it there excessively, you get slow flow. And of course, there are certain areas that you need to be treated very well. When you do an OCT in say such case, you can directly do an OCT, or probably you just put a small balloon there, dilate, and then may establish some flow and do an imaging there. When you do an imaging, what you see is, you look at this plaque here. If you treat this patient anatomically, like if you prepare here, it is a reflex that most of my friends, they do is, they put the balloon there at the tightest spot and dilate. The moment you do that, you get slow flow and you have problems. Instead, you do an imaging there, you clearly know that what is there inside this vessel here. Probably this area has a fibrotic lesion here. You can, if you want, you can dilate or prepare it well. But the tightest spot, what you see here is full of lipid here. You just concentrate. There is a ruptured plaque and then it's all full of lipid. You put a bigger balloon, dilate, you get a slow flow there. So when I do an imaging, I decide how to prepare this lesion. And then once what I do is prepare it, most of the times, if it is not a calcified lesion and then you are satisfied with the preparation of the fibrotic area, you go with a stenting there. And post-stenting also, imaging is very, very important. Most of the time, when you treat a lesion like this, we size it to the distal vessel. So to have a post-dilatation is one of the place where you get slow flow. So what you can do is, you can just do an imaging and just look at the area where you definitely feel there is an underexpansion or a malapposition. Most of the time, it is in the proximal vessel where you need to dilate, and then you get an excellent result like this. So in this patient, there was a proximal, a little bit of underexpansion or malapposition. Only the proximal segment was post-dilated and slow flow was avoided. And this is one more example. So this is, okay. This is another example of a patient where he had an anterior wall MI, and this is a common presentation that you get here. It's a proximal LAD total occlusion, and then you see the EDP is high. The patient is having an anterior wall MI, probably QRBBB or with sometimes complete heart block. You check the EDP, EDP is also high. So in such cases, probably you can do a thrombectomy or you can do a laser now if possible to dissolve the clot. And then you can put an IVUS also here. We have a lot of evidence with some of the studies showing that use of IVUS in acute MI has excellent outcomes. Generally, if you don't have a co-registration, what you can do is put an IVUS there. So this is the distal part of the IVUS catheter where we have started in an angiogram. You look at the pathology, there is not much of calcium there. You can see some amount of floating thrombus there seen in this. And this is the proximal part of the coronary where you have normal vessel. So your length of the stent is very clear. Actually I did this with almost a very minimal contrast, probably less than 5 to 8 ml of contrast. You will know the length of the lesion there. At the same time, I know the plaque characteristics. I know what to prepare or not. So once you know that, you take a stent there, deploy it there, a small puff to locate the ostial LAD. If you want, you can put IVUS here and see, but here I did with this and then deployed. And you see here, we avoid a slow flow and you get an excellent TIMI3 flow with excellent stent expansion. This is a very recent case where you have huge thrombus burden and then slow flow like this. Since we got a ELCA, so I have used a ELCA there to do a thrombectomy there in this case. And after that, of course, after ELCA, you do an OCT, you see here, there is some amount of thrombus there and you know the plaque characteristics. You can go ahead and stent this patient. And some case like this, an anterior wall MI is really tricky where you need a lot of things to do there. When you do this imaging in such case, you see what is happening. It is unlike the previous cases which I showed there. So this is a place where there is a calcific nodule which is very tight, and here your dimensions and your vessel sizings are extremely important. And then you go stent this pipe. We try to prepare this area with an adequate balloon dilatation, but in spite of that, you see what has happened is there is an area of malapposition due to the calcific nodule which is not giving way for the stent. But I always be careful because when you chase this nodule, especially the opposite to that, if the vessel is normal, which you cannot make out an angiogram, you make out on the imaging. If you chase it, you tend to perforate. So better accept this and come out. And this patient, of course, there was a good flow in the main vessel, but slow flow in the side branch because of excessive balloon dilatation there. A similar case here with an anterior wall MI. So when you do imaging, these are eruptive nodules. So these nodules are amendable for good expansion. You can make out the characteristics here. And then once you do that, it was well prepared with an OPN balloon and then stented. And here you see there, the area where there was a nodule, stent is well expanded. and excellent TIMI3 flow in this patient. And imaging is very extremely useful in deciding how to treat these patients with a simple anterior wall MI, which we have been, a simple STEMI, which we have been treating for last more than 25 years now. And apart from that, when there is an ambiguous anatomy like this, a patient like this, it will definitely tell you the etiology. Look at this angiogram, and you see that there is something going wrong, but the OCT clearly shows it's not an ACS. It is a spontaneous coronary artery dissection which has occurred, and that is why this patient had these changes. And look at the longitudinal lumen, it clearly gives that idea. And a lesion like this is not just an ACS, but probably it's a recanalized thrombus. All these things you cannot make out in an angiogram, and OCT definitely gives a very good idea, and IVUS helps you a lot in treating patients with STEMI. So imaging plays an extremely important role in STEMI today, and you can decide the treatment whether to defer it or stenting it, and of course during the procedure to produce an excellent outcome. Now coming to non-culprit vessel, why is it important is almost 50% of STEMI, they have multivessel disease. And we have evidence to say that complete revascularization is the best compared to incomplete revascularization. There is no doubt in that. But the problem is when to do the non-culprit vessel is always a controversy. Even today, we don't know when to do. So let us look at the literature. There are a lot of studies here, and the timing is a problem, when to treat them. And what we have is very important studies like COMPARE and COMPLETE and DYNAMI. What they have done is they have compared it even up to 45 days after an episode of STEMI. That is during index procedure or less than 2 days, less than 3 days, to 45 days. So probably you can select on this. And how to treat it, that, the guideline says that if the patient is very stable during the primary PCI, you can do it in the same sitting. Otherwise, you can stage it for a later procedure. And whether you want to do it angio-guided or FFR-guided is very important. And whenever you look at the evidence, these are the trials, DYNAMI, COMPARE, acute MI, COMPLETE. All this trial used physiology, FFR for the treatment of non-culprit vessels. And FLOWER MI was a negative trial. Whether FFR or not, it was the same, but FRAME MI is a positive trial. And now in ACS, you non-culprit, there is no doubt at all. But whenever you are doing a physiology, just remember one thing. If you are doing it the same index procedure, that is within 1 week or so, when you measure an FFR, probably your FFR might be falsely high. That is, you might underestimate the lesion. And if you are using a resting indices, probably you might be slightly overestimating the lesion. So just remember this point, and then probably proceed. If there is a gross difference, probably the FFR is around 0.75, 0.7, there is no doubt at all. A borderline FFR during an acute ACS is always controversial. Probably you can reconfirm it later. Use of adenosine is definitely there, but there are some cases where you cannot use adenosine. And as of today, you can do this non-culprit treatment up to 45 days since there are not much of randomized trial. In a non-culprit vessel, does imaging have a role? That is a very big question today. We have some studies, and Forza is one thing, and apart from that, new studies combined OCT FFR. In this, they found that if there is a TICFA in a diabetic patient, they do better if treated well. And of course, the recent PREVENT trial where they compared the MLAs and plaque burden and TCFAs, if it is lumen is less, plaque burden is high, you treat those lesions, you get very good result. So this is an example where this patient had an acute inferior wall MI. Circumflex was the culprit, and this is the LAD lesion now. So for how do you assess this? What I did this in the same session, I did a co-registered IFR and FFR study, and it is showing it is positive, and you can always compare this with imaging also. So when you do a co-registered IVUS, you look at this, FFR is showing this area is significant, and even here, imaging also is showing the plaque burden starts from here and from there, and it shows that if you treat this lesion, your FFR is going to be 1. So thus this was treated after treating the culprit. And similarly, this is another inferior wall MI, a patient like this. He has an LAD lesion like this. Should we just treat it medically or what is always a question. FFR was done, FFR was negative. And then what I did is, since he was a young fellow, we had some evidence to do an imaging in this. So I did an OCT in this. OCT clearly showed some important things. His lumen was 0.19, which are 1.9, thin cap fibroatheroma, and then it was definitely areas of healed plaques were seen, plaque disruption was seen, thin cap fibroatheroma, microvasculature, all signs of inflammation, cholesterol crystals. So keeping this in mind with Forza trial, which we are all familiar, I'll go fast through this. When you treat them on FFR, the mortality is high, or MACE is high at the end of 13 months, 8 to 3.4, and then target vessel revascularization also is very less if you treat such patients based on imaging and compared to FFR. So with this patient was stented, and then with excellent result. Initial lumen, which was 1.8, was expanded to 6.9 on image-guided PCI, and then that is the final result. So to conclude, imaging guides in both culprit as well as non-culprit vessel treatment, and it shows the pathology, and we know why this patient had an MI, and we can decide on the treatment also, whether to stent or defer, and it helps in preventing slow flow, which is a very important complication of primary PCI. And physiology is useful in non-culprit lesion assessment, and you can have complete revascularization. You can take up to 45 days, since we really don't have a concrete evidence to do it immediately. Thank you very much for silent listening.